Good morning, everyone. I know people are continuing to join us. My name is Colleen Gibbons. I've been working with you all on the Risk Need Responsivity series alongside AOC and alongside HCA for several months now. And today I'm joined by my colleague, Karen Otis, who has also been working across Washington State on several different projects, but she's joining us to speak to the responsivity side of Risk Need Responsivity. And we're really happy to have her and her clinical perspective to be able to engage with us today. So I'm going to go ahead and share our slides. And as you can see, today our topic is responsivity, spotlighting the second R. So we talk a lot about risk and need. And for those of you who are involved in therapeutic courts, you've probably heard over and over again, we serve high risk, high need, we serve high risk, high need. But this is a theory, and the theory is risk need responsivity. And in application, the responsivity is very important. And so we want to make sure that that really gets the focus that it deserves. So we're going to spend a whole hour talking about that today. Karen, I'll let you introduce yourself briefly. I have already spent enough time talking.
No worries. Good morning, everyone. My name is Karen Otis. I work with Colleen. I'm the Deputy Director on the Recovery and Reform team at the center. As Colleen mentioned, I'm a clinician. So the second R is my favorite R. And I will mention, I think it's the most important R. So I'm excited to talk about a little bit more about what the second R means and how we can make sure that we apply it appropriately for our clients. And I do use the term clients, so I think I'll bounce back and forth from clients and participants. Hopefully you won't mind that too much.
Thanks, Karen. So Karen and I are both with the Center for Justice Innovation. I know most of you are familiar with our organization at this point. We work on the Recovery and Reform team, providing technical assistance and expert assistance, and we've worked across Washington State for several years now. We also try to highlight the work of national best practices and the work that is done at the center in New York City at our operating projects and the research that is conducted throughout the nation on criminal legal reform and doing justice reform work. Our agenda today, we're going to briefly talk about updates to the All Rise standards. And by briefly, I mean we have one slide on it. And then we'll jump into the meat of this presentation, really looking at an overview of the risk need responsivity model, talking about why responsivity is important, highlighting the 3 types of responsivity, and then sharing how responsivity can be measured. We'll allow a little bit of time for discussion, Q&A, and then I wanted to point out that our next sessions are coming up. So in May, we will have an office hour session where you can bring your questions, your comments, thoughts, anything that you want to talk about with risk need responsivity. And then at the end, we'll share what our next steps are as far as presentations. So many of you are familiar with the best practice standards for adult treatment court. They used to be through the National Association of Drug Court Professionals, and they were called the Drug Court Best Practice Standards. But as they have been modernized, we use them and we understand them to be the adult treatment court best practice standards. We have, for a couple of years now, been working off the 2nd edition of the best practice standards, but this spring, this winter, and this year in 2025, All Rise has done some updates. You can see the image on the right. It says last updated March 18th. There's a new update actually from this image. They were updated again April 1st. And so when we're referencing the best practice standards, we are trying to reference the newest standards, but they are still in the process of updating some of the commentary and some of the research to include that in the new standards. So there are times when we might highlight kind of back and forth a little bit of what has been published previously and what is out there now. So we encourage you to download those, look at those, and really familiarize yourself with those standards. So we're going to talk about really the risk need responsivity model. And if you've been here for other of these presentations, You probably know the first part already, but again, we couldn't really jump into responsivity without talking about risk and need first. So there's three core principles to the risk need responsivity theory. The first is the risk principle. That tells us who we target, what is our target population, who do we want to serve in our therapeutic courts. The risk principle is based on mountains of data, looking at whether criminal behavior can be predicted. And really what that looks like is saying that criminal behavior can be predicted, the risk principle measures whether someone is likely to reoffend, is at risk of rearrest within 6 to 12 months from the point at which it's measured. And in risk need responsivity theory, the application shows that intervention for folks in our therapeutic courts is most effective if we treat high risk individuals. So it's great to have the high risk people, but then we also need to figure out what to target for them. And so in the application of risk need responsivity, we look at a need principle. What are we targeting? And so we measure criminogenic needs, things that people do, behaviors that people have that tend to fuel what is considered criminal behavior, what is causing them to behave in this way. Then today, we're going to focus intensely on the responsivity principle, which tells us once we know who we're targeting and what types of things we need to look at, how do we actually run an intervention? How do we change those things? And so we're going to be talking about interventions that are tailored to the needs, characteristics, learning styles, motivation, and cultural backgrounds of the individual that we are serving in the therapeutic court. So with that overview, we'll talk a little bit more about risk and need. So one of the things that's important to look at when we look at risk is that most people have an understanding of the word risk. It's something that we have a broad definition for. And so often when we're talking about risk need responsivity, people come in to this theory with a preconceived notion of what risk is. In this context, it is very important to note that risk is equal to the probability of criminal recidivism. As I mentioned, its likelihood of future justice system involvement, specifically within 6 to 12 months, and it's a risk of rearrest. That's what those data from huge national data sets have shown when we are measuring what risk is. It might be relevant to decision making, right? But risk does not equal clinical severity. It does not equal what the current charge is. It can be a misdemeanor, it can be higher level felony, right? Risk does not equal whether someone will appear, whether they are likely to fail to appear. And risk does not measure violence or dangerousness. Really, these statistical models say that we want to focus on individuals that have higher risk, but we need to remember what risk is and what isn't. So this is something, this language in this slide is directly from the treatment court best practice standards. And this is who we are identifying and looking at. We are looking at high risk and high need participants in our therapeutic courts. These are individuals who are, one, at significant risk for committing a new crime or failing to complete less intensive dispositions like probation, and it's important to have that and there, and have a moderate to severe substance use disorder that includes a substantial inability to reduce or control their substance use, persistent substance cravings, withdrawal symptoms, and or a pattern of recurrent substance use binge episodes. For instance, someone's use often substantially exceeds that person's intentions or expectations. This is very specific language, again, that comes directly from the treatment court best practice standards. It's also really important to note that there are therapeutic courts that do not always serve individuals with substance use disorders, right? Those can include mental health courts or veterans treatment courts. And the standards point out that in that instance, being high need also includes having a serious or persistent mental health disorder or some other significant treatment or social service needs, which could include a traumatic brain injury, insecure housing, or compulsive gambling. So there's a little bit of nuance in there. And again, we've talked about this in other presentations, and I will remind you that you can go to the Watts website to get a lot more information and background on high risk and high need. And you'll hear us and others presenting on that as well. It's very important when we are identifying folks, right? Not just to run through and look at a superficial level, but we want to look at our high risk and high needs participants and say, okay, we need to screen for what these needs might be, criminogenic and non-criminogenic needs. So individuals should be screened for mental health and trauma symptoms, and really look at what their treatment needs are. And then we'll be able to identify evidence-based mental health practices, trauma treatment, or levels of integrated treatment that can be provided. So that leads us into saying, what is the second R? What is this responsivity?
So with all of that background information, thank you, Colleen. Let's talk about the second R. As I mentioned, I argue that the second R is the most important R because that's where the change comes in. I often say we in treatment court are in the change business. Our goal is to help folks change their lives and improve their lives. But sometimes in treatment court, although our focus should be on recovery, we focus a little bit too much on punishment. We focus too much on sanctions over incentives. We focus too much on the static factor of risk. This person is risky or of risk, or the dynamic factor of responsivity. And so the emphasis on risk really doesn't help us move the needle on our clients. It doesn't impact change. It's called the static factor for a reason. It doesn't generally change. So in short, to be responsive to a participant needs, we really need to support those needs based on identifying those individual needs. And we can do that by individualizing our treatment interventions to the needs of each and every client that we work with. We have to move from the one-size-fits-all approach to address responsivity in a more equitable way. Our clients have similarities, as Colleen mentioned. They're high-risk, high needs. However, the needs may vary based on the individual's pro-social engagement, their strengths, their challenges, their ability to engage in programming, as well as the timing and availability of the services that we offer. All of these areas need to be assessed to determine and address the needs of the individual appropriately. And so that takes us to the next. Why is responsivity important? You can go to the next slide, Colleen. As I just mentioned, we work with individuals with high needs. And when we address those needs appropriately with individualized treatment services in a diverse, engaging, and supportive environment, and I want to really point that out, in a diverse, engaging, and supportive environment, we set up this space for optimal treatment for our clients. And so let's be mindful that, as to Colleen's point, when we reference treatment services, that we include any and all participant needs. Not just substance use disorder, not just mental health, and not just the 8 criminogenic needs, all services that they may need. And so tailored, or what we call individualized responsivity, you can go to the next one. Yep, you're on the perfect one, right? Those terms are interchangeable. So really effective in impacting our clients' receptivity, which is what we also call as engagement, identifying those needs will help us improve treatment programming. We also have to remember our clients are high risk and high needs participants. They have experience with the system, and a lot of them don't trust the system. And so there's some strong resistance that comes along with disclosing information. And so we need to build rapport with participants and work collaboratively with them in our treatment planning process, because that will increase their comfortability in sharing their needs with us and increase their program engagement. So the more that we can include the participants in the process, the more they will disclose their needs to us. And so also, as we're building the rapport and collaborating with the clients on their treatment planning, we have to also keep in mind the service providers that we work with, To maximize the engagement, the program should be partnering with diverse service providers with strong community connections for better efficacy when addressing responsivity. So to that end, responsivity should address clinical severity, as you see the change from the equal sign with the cross in it for under risk. In responsivity, clinical severity, responsivity addresses clinical severity and targets clinical severity. It addresses and targets social determinants of health, and it targets criminal thinking. Responsivity also should support the short and long-term goals of our clients that lead to recovery, and that's based on their involvement on identifying those short and long-term goals. And responsivity is the change. It's the change that we want to see to support our participants. So I'm going to hold there before we go. Any questions? I know I'm kind of probably doing this off cut. Any questions on that portion before I kick it back to Colleen to talk about the 3 types of responsivity?
Thanks, Karen. Folks that have been on webinars with me know that we are not afraid to allow a lag for people to formulate questions. So feel free to drop questions in the chat or raise your hand if you have something that you want to ask in the middle. If it comes to you, we want to make sure that we can address it. So now we will move into the 3 types of responsivity. Okay, so when we talk about responsivity, as Karen mentioned, it's very responsive. We want to be very responsive to the individuals that we are serving. And so when we talk about that, often we think of just tailoring to that specific person, right? But there's a bigger picture here. And for us to be able to tailor to that specific person, there's different layers that are involved. And so really what this starts with, the ability to do that responsive practice, comes in having an array of options. So we're going to first talk about systemic responsivity. And what that is really providing an array of programming that matches the need profiles of individual participants. This is not something that you as an individual clinician can create. It is systemic in that it needs to be built at a jurisdictional, institutional, and agency level.
So some examples of systemic responsivity at the jurisdictional, institutional, and agency level, and we're going to specifically talk about the courthouse or treatment court specifically, would be making sure that your program offers clinical case management, that you offer alumni groups, that you potentially have on-site childcare, that you have a peer on your multidisciplinary team to build in the systemic change, and that you consistently do community mapping and system mapping to ensure that you are working with a vast number of treatment or agency partners in a collaborative manner to respond to responsivity. We also suggest that community and system mapping should be reviewed and updated yearly and connected to every one of these institutional, jurisdictional, and agency levels. So when working with your substance use disorder treatment partners, those individuals should have a continuum level of care, including inpatient, outpatient, rehab, intensive outpatient, and self-help groups. Should be an option. And again, those should be included on your community and system mapping to make sure that you're as up to date as you possibly can. And then following with your agency partners, they should be supporting your clients with educational, housing, healthcare, medication, and that could be medication for health reasons or medication that goes along with MOUD and MAT, food insecurity, any of those quality of life issues. And again, all of those services should be listed in the community mapping and system mapping so that when they change, you can update that as frequently as you need to. And also the jurisdiction meaning the courts or the system is responsible for providing and developing a quality assurance matrix so that ensures that the institutions, the court itself, and the agencies that you're working with are providing the highest quality of responsivity for the clients. Now, we recognize that all these services may not be available in all of the communities, but that being said, the opportunity to work up to the optimal service needs is suggested. So building your jurisdictional, institutional, and agency wealth is beneficial for client responsivity. Because our goal is not to overpromise what we can do and underdeliver. It really is to make sure that we can match the responsivity needs of our clients with what's best possible in your community. So it's really important to keep community mapping as a part of the ever-changing landscape of treatment.
So that brings us to the next level, right? So now we have this, we started by talking about, okay, what does the system do? What are we doing in this broader category? And we're still not down to that individual level. There's this like subset. And this responsivity is termed general responsivity. So what does this look like? So this refers to the style and the structure of programs and delivery methods. How are we incorporating this? What types of an array of options do we have? So style and structure in this context can involve social learning, cognitive behavioral principles, and other treatment interventions that support change. It's not a one size fits all type of approach. And so where does this happen? Again, it's not at that broader community level, and it's not individualized. It's at the service environment level. And so Karen will tell us what this looks like.
So some examples of the general responsivity in style and structure looks like this. So let's start with style. Style includes person-centered, collaborative, client-led, gender responsive, culturally responsive, and trauma-informed responsivity. That's the style, while the structure includes didactic, group, peer and pro-social engagement, educational and manualized treatment, cognitive behavioral consequential thinking, emotional regulation therapy, and contingency management, just to name a few of what the structures could look like.
Tried to unmute and then I went wild with the slides. So I wanted to point out one of the things that was interesting. So the center was actually involved in a project that I worked on around general responsivity and looking at therapeutic interventions for individuals in opioid courts in New York State. And unfortunately, the project was done during the pandemic. So it didn't plan out the way that, or it didn't pan out the way it was originally proposed. But what it did was look at two different interventions for individuals related to journaling and the ways that folks in those courts would be able to apply those materials, right? And so that was in my head when I'm thinking about general responsivity, that's a good example of providing options for folks that might need those and looking at how that works for larger subsets and not just necessarily at that individual level. So now we're down to the part that we generally think about. When I think of being responsive and client engaged, really this is the point where we say, okay, we're individualizing. We're looking at those responsive needs for each person when they went through, right? If they've done an assessment, we're ticking off what are the things that this individual person needs. So where does this happen? The individual and participant level. And this is the specific responsivity piece of R&R.
So we've built up from the systemic to the general to specific, but to get to the specific for participant engagement, we have to identify the needs. That's the most important. And how do we do that? We do that through our assessment process. So our assessments need to be collaborative and comprehensive to identify every one of our clients' needs and to plan the responsivity outcomes. So assessment should include, and a lot of courts do not include, the ACE, the Adverse Childhood Experience Assessment, because that gives you information on how you plan going forward. Obviously, the criminogenic needs, which are the N and the R and the R, substance use disorder assessment, mental health assessment, social determinants of health assessments, so food insecurity, housing, and any other quality of life assessments that might impact our clients, including childcare assessments, transportation assessments. So working with that participant to prioritize not only just the needs, but also the dosage of the needs. How much do they need is really important, especially if you have limited resources in your community. And those needs need to be scaffolded effectively so that the participant is not required to engage in all of those needs at once. We know that we can't overload clients, specifically high-risk, high-needs clients. And so that would help to build the engagement with the proximal goals, the ones we know they can do now, the shorter-term goals that lead to addressing the distal goals as we move forward. And then we have to reassess. We have to reassess quarterly, if not at every 6 months, to see if the needs are improving, right? It's important that we mark and track the needs. We need to assess every 3 to 6 months to see what adjustments need to be made for the clients, and or if there are any additional needs that have developed over the time frame that they've been working with us. So the 3 responsivity types that we just talked about really work together, as to Colleen's point, to provide a really integrated responsivity approach. And that approach is collaborative and it is person-centered, or as I say, client-centered. The integrative approach focuses on the responsivity relationship between the provider, the services, and the participant. And it includes conversations about needs, on all of the needs, readiness, and change management, with the goal of increasing participant receptivity, or again, as we call it, engagement and programming. And it's tailored to the needs of the client and all of the needs, I'll keep saying all of the needs, for optimal recovery response.
All right, so we went through, now you have your overview. We've talked about why it's important for responsivity, what that looks like as far as those 3 layers and how to integrate them. And then the question becomes, how do we measure responsivity? It's not as straightforward necessarily as you would think from doing a risk need responsivity screening, right? This is something that is ongoing. So really we want to look at and say, okay, at these higher levels, how are we measuring systemic and general responsivity? And some of this Karen has already talked about in the ways that things are implemented, right? So looking at across the jurisdiction, institutions, and agency levels, what exists? What is here? Doing the system-wide mapping and not just doing it once, but revisiting it, coming back and saying, okay, we knew that this existed. Maybe our funding has changed. Maybe our organizations have changed. Maybe our laws have changed, right? And so how do we know what continues? What does this look like? So tracking is very important. Looking at MOUs, those memorandums of understanding between and across agencies, and looking at providers, right? And what are these community organizations? How are they engaged? What does that involvement look like? At the general level, right? So we know that the entities and organizations and programs exist, but then what does that look like within them, right? Are there differing styles and structures and different delivery methods? Are we sending people to the same 12-step meeting when we know that that's not the same way that everyone addresses their recovery? So that might be a responsive level on an individual level, but we need to be able to offer a broader array of diverse services, right? Are we remembering to offer tribal services that exist in the community? What does that look like? So making sure that these diverse programs not only exist, but are integrated and are offered up at this broader level. And again, you'll notice at both systematic and general levels, you see that word track, right? It's really important that this is something that is monitored. It's not just, oh, we started a program and now we know what's out there and we're going to just refer to that all the time, right? Or we're going to say, oh, we know the one person that does this, send them to that. Keep tracking, see what's out there, and keep revisiting. The data is very important in being able to measure these types of systemic and general responsivity. And then for specific, right? We are looking at very specific things. We want positive outcomes for people. Are our participants and our clients, as Karen says, engaged? What does that look like? Are they taking advantage of the services that are provided for them? Are we looking at what their needs are and being responsive to what we're offering? Are they learning, right? Are they able to move forward with some of the direct and specific skills that these programs are addressing? Are they utilizing that? Are we seeing them progress? And yes, we know in a therapeutic court, especially when we're working with high risk and high needs people, that there is a likelihood of returning to use and that their trajectory is not going to be straightforward. But are we seeing them begin to utilize those cognitive models to say, yes, I know I returned to use, and here is the reason why, as opposed to making excuses or moving forward? Are they using the skills that they are gaining? Are they achieving short and long-term goals? What does that look like? Are we tracking that? Are we revisiting what their needs are based on, you've hit this goal, now what do you do next, right? Where do you want to go from here? Not you've hit this goal, great, you're good, go ahead. And what do the goals look like after that? And are they improving in their functioning? Are they moving forward in a therapeutic, cognitive manner? One of the things, so when we were building this slide, right, like one of the things we talk about, and when we look at the risk model, right, it's measuring for recidivism. Recidivism is a secondary measurement. That is something that, yes, we want to look at. And when we're tracking our therapeutic cohorts, we want to say, okay, great. This person was very successful as a whole. This is our rate of recidivism. But when we're looking at individual growth, we are tailoring responsivity to the folks that we are serving. And that recidivism is something that demonstrates that the work we are doing is successful broadly. But again, we're focusing on our individuals and making sure that they are the ones that are working through and building recovery for them. Wow, we really blew through that, Karen. We were very worried about the fact that we are both very talkative and that we weren't sure that we would have enough time to actually have this. So I'm going to point out what our next session is. Again, our office hour is May 8th. So we'll talk about risk need responsivity. And then in June, we're going to flip a little bit and work on and move from an R&R to an RED. Instead of focusing strongly on risk need responsivity, we're going to feature a session on racial and ethnic disparities. And I believe it will be June 12th, but we're not fully committed to that yet because we're working on building out what that programming will be. So be on the lookout for that. I know that's 2 months down the road and we're all thinking about summer, but we're not really there yet. So that's what's coming up next. But I want to then stop because on our agenda, we had Q&A and conversation. So after Karen and I talked about all of that, what kind of questions or feedback or thoughts do you have about this responsivity piece?
Good morning.
Hi, Jamie. I always love seeing your smiling face.
Thank you. Great presentation. It was a lot of information and I took some notes. But where will the recording be? Because I would like to re-listen to the presentation, specifically regarding the systematic responsivity, because I think that has some things we're doing in Snohomish County. So where can I find the recording of this?
That's great. It will be on the Watts website. Let
Okay.
me see if I can share it in the chat.
Hey, Colleen, I just dropped the
I
link
think
in the
Rachel
chat.
did.
Yeah.
Yep.
Great job, Rachel. Thank you.
Thank you.
And then regarding the assessments that you were talking about, so it's like the ACEs and the criminogenic needs and everything and the healthy. So we're using a recovery capital assessment. Is that that's basically, I think, what we're doing to capture our responsivity and do individualized plans. I just kind of want to make sure that that's encompasses what we're talking about.
Yes, absolutely. That is another assessment tool. I think the most important thing is that you're assessing for every need you can find. So, you know, there's no one size fits all. Most folks just focus on the addiction severity index to give them information. There are more assessments that can give you more information to make sure that you're targeting those needs. That sometimes what happens is folks don't fully disclose everything. And so you want to not over assess, but assess adequately. And so that means you may have to use multiple tools.
Okay, great. Thank you.
I see a question from Sarah in the chat. It says, can you describe a little more about how to conduct the system mapping to make programs more responsive to client needs, or what we should be looking at more closely? I'll start a little bit and then I'll turn it over to Karen, because I think there's a couple layers here. So the system mapping really can measure several different things, right? So you want to look at it from that systemic level to say what exists and what can provide the services that we need, right? Is there a need for a different therapeutic court? What is happening on a county-wide level? What services are out there? What funding is there? What mental health providers do we have, right? Looking at that from that bigger perspective is the start of that map, right? And then kind of tailoring it a little bit, right? When you get into general to say, okay, so now we know who the providers are, but what are they offering? What is the subset of offerings that they have, right? That could be, right, that you have a system roundtable and you say, okay, talk about what you have, or bring your program materials, or let's hear what is actually being done in these spaces, so that you can understand that a little bit more, right? And so being able to then have that, then I think you take it down to that individualized level and be able to get some feedback from the folks that you are working with to see whether what is spoken about and what is offered is responsive to those individual clients, right? Because sometimes we're going to hear that, oh yeah, we offer this, and then we hear the feedback around what happened in that, and that might not actually be therapeutically beneficial for several of our participants. And Karen, go ahead and add. That was my overview.
Perfect. I'll give an example of what we've seen in some of the work. So some treatment providers say they offer manualized treatment. And when the treatment court went to visit, they found out that they offer sheets out of the manualized treatment curriculum, not the actual manualized treatment curriculum. And so they were presenting it as if they were doing manualized treatment from soup to nuts, and they weren't. Because the court went to visit and had engagement with the provider, they were able to course correct and say, this is not what our clients need. It's kind of like if somebody's doing MRT and you're skipping every other week, you're not offering MRT. So once the court went to visit, they were able to correct that. And so the program then instituted the actual full manualized curriculum. So that the clients are getting the full responsivity need addressed in the way that they should. So that's an example of how the system mapping in the 3 levels work. I just want to mention, did you see, Tessa, do you want to quickly mention what you dropped in the chat?
Yeah, I'm happy to. So that kind of higher level that Colleen talked about, that can fall into the sequential intercept mapping model. We have, well, there's 24 facilitators across Washington state of all disciplinaries who work with us to facilitate SIM mappings across the state. I will drop Alex's email in the chat because Alex coordinates our sequential intercept model mapping. And if you're not familiar with that SIM mapping, you're going to walk away from that having worked with your community to build that deeper dive that Karen was describing, where you're actually diving down into the service providers and seeing what's really happening. So if you're interested, please reach out to Alex. I'll drop her email in the chat and we can give you a brief overview of what it looks like to engage in a SIM mapping event and help you get started.
Thanks, Tessa.
I want to go back to something that Karen mentioned and just build on that a little bit. So Karen says, hey, we went to this court and they said that they were doing this type of treatment, manualized treatment, and then we learned that they weren't. I am an attorney. I know nothing about manualized treatment, right? This speaks to the power of our therapeutic courts, because someone could say, hey, we offer manualized treatment. I'm going to write that down and say, great, they offer manualized treatment. And then our judge is going to say, hey, why isn't this person doing this, right? But in our therapeutic courts, the way that they are designed, the best practice, we have a treatment provider, we have potentially a peer, right? We have the judge, we have the attorneys, you have a case manager, you have a clinician, a coordinator, right? And so there's enough people built in to be able to build that responsivity model in an appropriate way. Because if it was just a regular court, you're not going to have that person that actually understands the way the program should be run. And so I think it's really important to lean on the service providers, lean on the case managers, and make sure that they have the ability to bring in that responsivity piece. Christine said, can I ask what steps were taken when it was determined they did not offer the treatment?
Well, I will say, I'll give them credit that it wasn't that they didn't offer the treatment, they didn't offer the full complexity of the treatment. And so the coordinator met with the program director and talked about the need for making sure the curriculum was the full curriculum, and they adjusted to offer the full curriculum.
Other questions, comments, takeaways?
I generally love sitting in silence as a clinician, so I don't mind it, but I just want to just reinforce the importance of the second R. I know, again, as I mentioned earlier, you know, we are in the criminal legal system and we deal with folks who have been in our system for a very long time. But our goal, as I always say, to be in the change business, we have to make sure that we offer every opportunity for change. And so keeping that in mind when a client might be what we would say struggling a bit, that we have to think about sometimes outside of the box of ways to address those needs, no matter what those needs are. It's really important. So responsivity is the way to move someone forward, not recidivism. Recidivism actually can be an outcome of poor responsivity. So I just want us to think about that second R as a primary factor, not a secondary factor.
Great point, Karen. Well, I want to thank everyone for attending today. Again, we will follow up. This will be posted on the Watts website as soon as I am able to download it and send it along. And if there's any questions, I'll follow up with an email to everyone who attended today with a survey. You're welcome to put ideas around future R&R sessions in that survey, and also provide any additional feedback you have. And always feel free to send an email. So thank you, everyone. Enjoy the rest of your Thursday.